and it's a lot. So you have to strengthen your learning abilities, and then you get those videos. Patience, you have to think about it. Okay, let's talk about maternity nursing. So I am not talking about the reproductive system. I assume we already know the anatomy of the reproductive system. Okay. So I assume you already know it. And if you don't know, I'm not going to go into details about it. I'm going to, let me see if I can share this one here. So I'm just going to share this image of the reproductive system here. And as you can see, I focus only on the female aspect, even though I have the male onto there. But this here is the vagina, the cervix, ovarian ligaments. This is the ovary and fallopian tubes and the uterus. So we know that when a lady is pregnant, there's fetal attachment. So it starts with this. So this one, the ovary here will pick up the egg, and then it starts nourishing and fertilization starts, and it goes straight into the uterus. So any baby or any pregnancy that stops here in the fallopian tubes and does not proceed and start getting bigger here. So let's say instead of moving in, the fertilization have occurred here, but it's not going all the way down to implant itself here. There's no plantation here. So if it stops here, that's where we have the tubal pregnancy. That's where we have the ectopic pregnancy. So ectopic pregnancy being outside of the uterus will be somewhere around the ovaries. So if it's there and the baby keep growing, the woman start complaining of pain and start bleeding and symptoms start coming. When it ruptures, that's ruptured ectopic, then there will be a burst. So this one is just a tube and cannot contain the increasing fetus. So when it bursts, it becomes ectopic pregnancy. So this one, anytime there's a burst of it, is always a medical emergency. But I'm not intending to go into detail with the reproductive system actually. So I'm just going to go straight to prenatal visit or prenatal period. So gestation, the time, this is the time from fertilization to the time of delivery. Usually the estimated days will be 280. How many of us know how to calculate the gestational, know how to calculate the expected date of birth using this rule? How many of us know that? If you know it, let me know. If you don't know, let me know. Or if you don't remember, I know we all have heard it somewhere in school, but we may not remember it. How many know of it? If you know it, let me know. Who know how to use the Nagel's rule? Because usually NCLEX will give you questions and they want you to be able to determine when the child will be born. They want you to determine when the child will be born. So with that rule, you use the menstrual cycle. So if your last menstrual period was 25th December, then I see somebody sent me a chat. Okay, yes. So you use, so if the last menstrual period was 25th December, you add 3 days to it. If someone doesn't know, just write it. You write it. I'm moving fast. So you add 3 days to it, and then no, you subtract 3 days and you add 7 to it. You subtract, so you take 25th and then you subtract 3 months and you add 7 to it. So when you add the date that it will fall will be your the expected date of the child. Now let's talk about gravity and parity. Does anybody have a question with that I've said? Or the other way is for you to count 3 months back. So you take 25th February, so you count 3 months back, then you add 7 days to it. That's another way of using the Nagel's rule. So when the NCLEX presents to you, that's what you want to know, because you will answer questions under that. So let's talk about gravity. Gravity refers to pregnant women. Pregnant women, how many pregnancies? So if they say gravity, gravity is pregnancy. Then we have the parity. Parity is the preterm, the births, the number of births you have, a number of children you have given birth to. So take note that if I am pregnant for one, if I am pregnant for one and I give birth to twins, then it's one pregnancy. It's not considered two, it's one pregnancy. So use this one. This is just a term that describes how you would describe a patient that is pregnant. So when they present to a question and they want you to be able to use this and they put the acronyms, you should understand that this G is gravity, pregnancy, T is term birth, how many children were full term, and preterm births and abortions or miscarriages. Then we have current living pregnancies. That's what this one means. So with the living pregnancies, with this one, any pregnancy that is up to 20 weeks, any pregnancy that is up to 20 weeks, and then the baby does not stay till term, or the baby is not born, or the mother decided I'm going to have an abortion, is still counted as an abortion and miscarriage. So before 20 weeks, after 20 weeks, we count it as a viable child that that is supposed to be a preterm birth. Now let's talk about pregnancy signs. So pregnancy signs, we have the probable signs and the positive signs. So where you don't have your menstrual period didn't come, you have nausea, vomiting, increased size, your uterus start getting bigger, or your stomach, pronounced nipples, your nipples become prominent, urine frequency, you start urinating because the uterus is getting big and putting pressure on the bladder. Then you have the quickening. The quickening will happen usually around the 16th week for new mothers, and for those who have given birth, multipara, they will have it earlier, at least like 12 weeks, you would have started the baby moving. But before that, by 9 weeks, the baby start moving in the stomach. Now we have the probable signs. Probable signs are signs you see that there's uterine enlargement. You physically see it, but the positive signs are diagnostic tests. Those are diagnostic tests that will be done. So usually they will use a Doppler. They'll use a Doppler or they will use a vaginal probe, and they try to diagnose if you are really pregnant. Or fetoscope, they hear the fetal heartbeat. Or they use, they do urine pregnancy to test it. And then after that, they do the beta HCG level. The beta HCG, human chorionic gonadotrophic hormone level. So they use the hormone level, and that they can use to check how many weeks you have been pregnant for. So the positive signs are the diagnostic ones that they usually do. But for the probable signs, you, the mother, you will be able to tell as well when you see your uterus start enlarging, you see your breast becoming tender, you miss your period, and you have the Goodell sign. This is softening of the cervix that occurs at the beginning of the 2nd month. So at the 2nd month, you start feeling that. Then we have the Chadwick sign, violent coloration of the mucus of the cervix, vagina and vulva, that occurs about weeks into the pregnancy. So the first few weeks, you start seeing that, you start having a lot of discharges coming out. Bartholomew's sign, Ballottement sign is rebounding of the fetus against the examiner's fingers on palpation. So when you palpate, you feel a rebounding of the fetus. Now let's talk about fundal height. Let's talk about fundal height. I spoke about this diagnostic test. They get the fetal rate, the fetal heart rate by electronic device. That's the Doppler. And we know the Doppler, right? Do we know a Doppler? They use that to listen to the baby's heart rate. I have one inside my room, but I can't get it right now. But that's the Doppler is just a small machine that has the transducer on it. They put a gel on it that will transmit the baby's movement. So during the 2nd and 3rd trimester, where am I? Yes. So we have the the active fetal movement on palpation as well.
This one they wish you.
Positive, which is a positive sign of pregnancy, the active movement of the fetus in the stomach. So we have an ultrasound that they will do to confirm pregnancy. So mostly a confirmed pregnancy is the one that has undergone through a diagnostic test. So let's talk about the fundal height. I did have a picture of the fundal height to show you. Let me see if I get that picture. Okay, so before I get that, let me just go over this. I'll show you guys the picture. The picture is there for your memory. Sometimes when you are studying, that's why I like to add the pictures. Sometimes it's not everything that sticks in your mind, especially if you just have to go and take this test. Sometimes when you see a picture, it gives you a click back. It gives you a reverse of what you have seen. So sometimes your eye will remind you of where this is located. So you get a question and your mind take you back to the image. Or sometimes it's somebody's voice you will hear, and that's what will click your mind. So we have the fundal height. It is measured to elevate the gestational age of the fetus. So every time a pregnant woman goes to the doctor, they use the thing to measure the fundal height. You measure the fundal height. So if you know this woman is 20 weeks pregnant, you should know the normal. That's the one I want to show you in the picture. During the second and third trimester, weeks 18 to 30, fundal height in centimeters are approximately equal fetal age in weeks plus 2 centimeters. It's approximately equal to the age of the fetus. So it's approximately going to be 28, 27, 30. It's approximately equal or less than that. I'm looking for the picture. I'm going to show you the stage by stage of the fundus of the uterine pregnant uterus. Okay, I think that's taking my time. I don't want to waste too much time on that. I'll get it later. Okay, so I was telling you about the fundal height when they measure it. I'm not going to dig into it because it's not really what you need to pass this. It's content. You need to know your analysis. You need to just have understanding of them so that when they're asking you a question and they twist the question, it brings your mind back to what the normal should be. So I like to tell students that if you don't know the normal of something, you cannot pass this exam. If you don't know the normal of of a human being from head to toe, what is expected of the person, and then a disease process come in to mix with the person, there is no way you'll be able to answer correct questions. You'll be missing out. So at 20 to 22 weeks, the fundus is approximately at the location of the umbilicus. 20 to 22 weeks, the fundus is approximately at the umbilicus. Then at 36 weeks, the fundus is at the xiphoid process. When assessing fundal height, you monitor the client closely for supine. Monitor the client for supine position. Then active fetal movement palpable by examiner. So after 20 weeks, the movement of the baby will be more palpable. You'll be able to feel the baby moving more. You touch here, the baby move there. You put the Doppler here, the baby moves to the other side. So outline of fetus is via radiology or ultrasound. They do an ultrasound to be able to outline the fetal structures at 20 weeks. So when you're assessing the fundal height, you need to monitor the patient for supine hypotension when placed in the supine position. So you know that to assess fundal height, you have to position the patient supine. So never forget that position, especially if you have been pregnant before. You will remember that before you do your assessment on a woman, they have to be in a supine position. So be mindful of supine hypotension. So physiologic maternal changes. Physiologically, what do you expect to see in a woman who is pregnant? If a woman is pregnant, what do you expect to see? So culturally, we often have culture. Okay. So culture often determines our health beliefs, values, and family expectations. Therefore, it is important for us to assess the belief of a client. So if you have a maternity patient, you have to assess their cultural belief first. Now, when a woman is pregnant, there are so many physiological changes that a pregnant woman goes through, starting from cardiovascular to respiratory. All the systems are impacted. Remember, the body is struggling to create a human being. The body is adjusting to hormonal imbalances up and down. Just like a woman going through menopause will go through a lot of changes. So we have the cardiovascular system of a pregnant woman. Circulating blood volume will increase. There will be increase in blood volume. Plasma will increase and total red blood cell volume will increase. This is why most pregnant women are at risk for anemia, because there's increase in blood volume. The mother and the baby have to be able to share. So there's a possibility of physiologic anemia, and this occurs as the plasma increases. And usually blood volume will increase, will double. The need for blood volume will double starting 34 weeks. And then it starts reducing before giving birth or towards the end of the labor days. So the heart size will also increase. The size of the heart will increase, and the heart is elevated slightly above and the left, slightly above and to the left because of displacement of diaphragm as the uterus enlarges. If for some of you who were there with GI system, I had explained to you, no, is it GI system or respiratory system? I had explained to you why, no, cardiovascular system, why the heart pushes the lungs, the right side of the lungs is on one side, is because the heart was putting pressure on it. Now the uterus is increasing. We have talked about the fundal height. So as the fundal height increases, starting from the xiphoid sternum, it is xiphoid process going to the umbilicus, and then it goes up a little above the umbilicus, getting to 24 weeks over in the pregnancy. As it keep increasing, the uterus keep growing and increasing in size. It put pressure on the heart, and the heart is supposed to increase to be able to accommodate volumes of blood that comes in. So if the heart is supposed to increase and the uterus too is increasing, it puts pressure and displaces the heart more to the left side. So this displacement causes a shift, and it's because of the increasing fetus in the womb. Now let's talk about respiratory system. Oxygen consumption will increase, so the woman will need more oxygen. You do something small, you get so tired. So during pregnant women, the pulse rate may increase about 10 to 15 beats per minute. So if the normal is 100 and I come in and I'm 105, it's supposed to be expected, because it's not too bad, because that means my heart rate has increased due to the pregnancy, even though we expect a normal heart rate in everybody. But when you see an increase of 10 to 15 beats per minute, the blood pressure also will slightly decrease in the second trimester. So in the second trimester, the pregnant woman's BP will slightly decrease. Remember, I had mentioned that the patient needs more volumes of blood. So there will be approximately 40% to 50% increase or demand for blood volume in the pregnant woman. So oxygen consumption will also increase by 15 to 20%. So let's talk about GI system. What is it about GI system if I am pregnant? So we know nausea, vomiting in the early stages of pregnancy. This is as a result of the increased level in the hormones. We have the HCG hormones that moves back and forth. So we have nausea, vomiting occurs. We also have poor appetite, especially in the first trimester. Alteration in taste and smell may occur. So a pregnant woman's nose is very sensitive. They can smell what any other person will not be able to smell. So we have constipation. The problem is also constipation. Pregnant women have a problem with constipation. Heartburns, if you can bear with me, they have heartburns. Hemorrhoids. So hemorrhoids may occur as a result of increase in venous pressure. We have gum tissue may become swollen. This is why pregnant women need to go for dental care. So if a woman is pregnant, dental care is part of their prenatal care plan. We have excessive salivation. That is called pitulism. Please, there is one thing about NCLEX. NCLEX like to mention names that are not so familiar to you. They like to mention names that you are not so good in knowing them. So when you are studying for this NCLEX on your own, and you see they are mentioning some names, sometimes it's just a trick to trick you to get to see if you understand that the other name for hypersalivation is pitulism. So if they put pitulism and you don't understand it on the exam what that term is supposed to mean, then you wouldn't know which one to tackle as the answer. So you have to take notice of some of those things. And if I remember, I think I captured that in the weekly tips that I send you guys. So for Juliet, I am going to send you everything and then you just learn them. I have a bunch of information for you to study actually. So I think I'll load it too much. Reproductive system. I have the uterus. So uterus enlarges. We have talked about the fundal height. So the fundal height is as a result of the enlargement of the uterus. So if the uterus is enlarging, we are measuring the fundal height to see if it's in order. So if the baby is not growing so well and you are measuring, it will be lower. You will not meet it per week as demanded. So there's enlargement, and approximately it increased in mass from 60 to 1,000 grams as a result of hyperplasia. That's influence of estrogen and hypertrophy. So because of the hormonal level that increases the growth rate, you will see that the uterus will increase from 60 grams to 1,000 grams in a pregnant woman. Your uterus become heavy. So the size and the number of blood vessels and lymphatic veins, they all increase in their supply because there's the need to supply more blood to this uterus. That's why when you have a woman go through postpartum hemorrhage, the bleeding is so severe because a lot of blood volume had increased in the body and the vessels are all activated due to the hormonal increases, and then it's just oozing out blood. It bleeds a lot. That's why it's a serious risk that can kill. Now let's talk about the cervix. Before that, let me make this one too. So irregular contractions occurs typically beginning after 16 weeks of gestation. So if a woman is pregnant, by 12 weeks, you will not feel any like contractions. But after 12 weeks, 16 weeks, you start feeling some irregular contractions. They are not things that will alert you to run to the hospital. They are normal contractions. They are not regular. So starting from 16 weeks, you start educating the pregnant woman. Take notice of that. That's the education you do for NCLEX. You start educating the pregnant woman about irregular contractions. And then you teach them to monitor what is normal and abnormal contractions. So no problem, Juliet. I understand. It's fine. So if you have any question, just type it in the chat room. I will get it. I have my chat open, so I'm monitoring the chat as well. So anyone that has a question, just put it in the chat room. I will get it. Then we have the ovaries. Did I talk about the cervix? No. So the cervix becomes shorter, more elastic, and larger in diameter. So in as much as the fetus is growing, the hormonal changes, it affects all these parts of your body. So the cervix too have started preparing. So it gets soft and shorter and more elastic and is larger in diameter. That's the one that will dilate to have the baby come out in the end. So there's increased vascularization and an increase in estrogen that causes the softening and a violent discoloration called the Chadwick sign. This is one of the probable signs for diagnosing a pregnancy, the Chadwick sign. And this one occurs about 6 weeks of gestation. So you will see bluish discoloration of the cervix. That is the Chadwick sign, and is usually at 6 weeks. It's a probable sign of gestation or sign of pregnancy. Let's talk about the ovaries. What happens to the ovaries if a woman is pregnant? A major function of the ovaries is to secrete progesterone for the first 6 to 7 weeks of pregnancy. So the ovaries still do secretion. We know the ovaries is the one that carry the egg, and it will do secretion of progesterone for the first 6 to 7 weeks of pregnancy. The maturation of new follicles is blocked. Ovaries cease ovum production. They don't produce. So instead of producing the ovum to cause menstruation, they cease to produce. They rather start secreting progesterone. Progesterone is more of a male thing that is secreted in male. But now, because the woman is pregnant, the ovaries does not produce any egg anymore. It tends to secrete more progesterone. And this is what the estrogen try to balance. Estrogen is more for women. So estrogen tries to balance the progesterone level, and then you see the reaction. That's why you have nausea, vomiting, you have hyperemesis, and all those stuff come into play. Now let's look at breast changes. I have vagina before that. So the vagina will hypertrophy and thicken and become thickened and muscular in shape. So it will become harder. Then an increase in vaginal secretions. I spoke about that. It will be white and acidic vaginal secretions, usually thick. So you see thick secretions that are white. It's not UTI, it's not vaginitis, it's not yeast infection. If there's pregnancy, you would expect that to happen. Now let's look at the breast changes. Your breast become tender. I'm gonna jump some of this breast stuff. The breast will become tender. So when you are assessing, I'm taking the pain to go through all this for the purpose of the NCLEX. Sometimes, okay, Clementina, I got your message. Okay, so when a woman is pregnant, the breast changes also occur. Like I said, any organ associated with the reproductive system, we see that cardiovascular is not reproductive, is affected. Respiratory is not reproductive, is affected. That's all the body system trying to compensate each other to function for a human being. So when you are assessing a pregnant woman and they tell you the pregnant woman has shortness of breath in the NCLEX, you need to be able to correlate this as the fact that there is increased blood volume. And this is one thing that always also can lead to preeclampsia. And then you can also have congestive heart problems. You can have edema leading to eclampsia, preeclampsia. So this is how all of them are related. So you need to understand this for the NCLEX, that if I am pregnant and they are talking about eclampsia, hypertension setting in, I didn't have a history, but you need to also have the mindset that there's increase in blood volume and blood supply. The heart needs to do a harder job. For those who did the cardiovascular, especially the left ventricle will have to push more volumes of blood out of the body. And the pulmonary system is also affected. That's respiratory system, because the pulmonary vein has to carry blood in and out of the lungs to put more oxygen. So if oxygen supply has increased, the patient now need more oxygen, 15 to 20%, if I remember what I had said before. So if oxygen supply has increased for respiration, 15% increase, that means the lungs will also need to do more work to be able to oxygenate all the blood that gets inside the lungs. So this is how those things are related on the NCLEX. You should be able to understand that this is what they are talking about. So the moment they start talking about preeclampsia, they want you to educate the woman what to do. Then you now go into specifically preeclampsia. But if they want you to educate a prenatal mother who just came today, a preemie mother, preemie gravida, the first time pregnant mother, the first time I'm ever pregnant, and I come to you and you are the nurse. And I ask you, oh, they gave me all this information to go and read. Can you just tell me everything about this prenatal stuff? What will you do? So you need to be able to educate this patient. If the answers are giving you 4, that means they're limiting you to do 4 things, and they want you to be able to do the most of all. So you look at all the most of all, what is more of a need to the woman right now. What do you need to tell the patient right now? So if they put all the symptoms, and then you see that they put the fundus increasing, you see they put the patient not able to walk, they put tiredness, they put loss of appetite, nausea, vomiting. You want to be concerned about nausea, vomiting, because that's the first trimester. So when you are teaching the patient in that category, you start from what the patient is going to start feeling from the point. So if the patient is 3 weeks and is here, you should expect some of these symptoms. So you let the patient know in your education, these are expected symptoms. So apart from bleeding, when you have nausea, when you have your breasts appear tender and a little swollen, they are all expected. When you see a lot of discharges coming, it's not UTI, they are normal, but you describe the normal discharge. It should be whitish, and it should not be foul smelling or something like odor. There should not be bad smell in that. And there should not be burning on urination. If that happened, that's a different problem. It's not related to pregnancy. So you talk about the size of the nipples will increase and they become tender. Nipples become more pronounced. The areola become darker in color. This is just preparing for breast milk production. And remember, we also want to teach the mother about self-breast examination as the hormonal levels are increasing. So breast examination is also necessary. So colostrum may leak from the breast. Some women, the moment they get pregnant, they start having the colostrum come out even before the baby. Now, skin changes occur because the level of melanocyte stimulating hormone increases as a result of an increase in estrogen and progesterone level. These changes include the following: increased skin pigmentation. So you see dark streak down the midline of the abdomen. This is the linear Niagara. You see it on your abdomen, how the line gets bigger, and it gets thicker or darker by age of pregnancy. Then, so if a pregnant mother is concerned about that, the pregnant mother is concerned about that linear Niagara, you want to explain to them that it's not actually a big deal. It's a normal thing that will appear with the pregnancy, and it goes away after you have given birth. It does take time. After delivery, it will stay. It will be there for a while, but it will gradually go away. And you let them know it's as a result of the increased pigmentation due to the pregnancy hormone, estrogen and progesterone. So you want to understand that estrogen and progesterone controls reproduction and controls pregnancy stuff. So it causes a lot of changes. So all these changes are as a result of increased progesterone production by the ovaries, and then estrogen trying to balance it, and all these symptoms are occurring. So when you're teaching a pregnant woman, please look at what is necessary by the fact that you understand what the prenatal period will carry. Skin color will change. You have musculoskeletal changes too. Another thing you will talk to the pregnant mother is about this. Reddish purple stretch, the stretch marks. This is a concern. It's physiologic need It's a physiologic need. It's not like ABC need. It's a physiologic need because you want your body image to look good. The ladies, we like to look good. So if the woman is having striae on the abdomen, you also want to prepare their mind that this is what will happen as the stomach or the uterus stretches out the abdominal muscles. It all stretches out, and then this can cause it to appear. So you advise them to be putting lotion on their stomach and all that, but this is part of the pregnancy changes the woman might go through, and usually it doesn't go away, unfortunately. But sometimes after that, people go through plastic surgery. So you are not actually recommending plastic surgery if the patient don't ask you in your teaching, but you are just educating the patient to let the patient know it is part of the pregnancy changes, and the skin is also affected by pregnancy. The musculoskeletal system. So there's changes in the center of gravity beginning in the second trimester, and this may be caused by relaxin and progesterone. That's the same hormone as well, progesterone, like I said. There is curvature, your lumbosacral, what's the name? Curve. Your spine, it curves down. So you see a pregnant woman curve this way. This puts pressure on the spine in the back. This is why pregnant women have back pain. So when you are educating a pregnant woman who comes to you and tell you, after I have this baby, I still have back pain for 1 week now. It is still part of the process. It gradually does go away. Sometimes people have permanent damages to the meninges in the back, but it's like, it's part of the curvature formation in a pregnant woman. So as the fundus increases or as the uterus keeps bumping up, it's bending the woman, like it's scoliosis. It's making you bend upside down. So you let the mother know that is also going to happen in the pregnancy. So back aches, body weakness, they feel tired, they always have this pain and you cannot stretch. They are all discomfort, and you let them know it does go with the stage of pregnancy. So the first few weeks, the first 12 weeks, you may not have that, but after 20, 24 weeks, your stomach start pushing up higher, you start having that. So during pregnancy, postural changes occurs as the increased weight of the uterus causes a forward pull of the bony pelvis. So it pulls your bony pelvis up and it curves your spine. So this is what you want to tell the patient. And it is important for the nurse to encourage patients. So anytime they say encourage, it's part of your teaching. So you encourage or you teach the client to implement measures, to put in measures that will maintain safety and correct posture to prevent backache. So they're going to have backache, but you tell them to try to sit elevated and to try some pillows in the back. These are minimal invasive, minimal steps. You just tell them to help relieve their comfort. Yeah. Okay, Amelia, no problem. I'll be putting you in and out as you go and come, okay? So we have physiological changes that occur. Ambivalence may occur early in pregnancy when pregnancy is planned. When you plan, this is psychological. We all know psychological preparation. When you are prepared for the pregnancy, is different from especially somebody who's not ready to get pregnant. Let me not go there. Now let's talk about acceptance. So acceptance is when you are prepared for it, you are ready for it, you are not worried, you accepted it, you want it. But where you are not interested and you get pregnant by accident, that's where there's a problem. So women will present with you, or NCLEX will give you women that have come, especially now that abortion rights are going back and forth. No, right now I don't even know where we fall, how many weeks or whatever is I'm supposed to do if I want to take out my baby. But now that this right will come in, the NCLEX want to know if you understand or if you know what to tell a mother who tells you that I didn't want to get pregnant. Can I just take this baby out? So the first question you want to ask yourself is, how many weeks is the baby? The woman already told you their mind and everything. So you need to know is the baby up to 20 weeks? And if the baby is up to 20 weeks, are there problems? Do you have a prior history of risk pregnancy? What is putting you at risk to think this way? So you further want to assess into that statement to understand the woman's point, but you are not advising her not to do it or to do it. So you have to be a nurse standing on your point. This is the patient's request. You just want to get more information before you follow up on that. So you further question the patient. So acceptance is when the woman is ready for that. So if the woman is not ready for that, you have to take them through coping process. Then we have emotional liability. Emotional liability may be manifested by frequent changes of emotional state, of extremes in emotional state, extremes in emotional state. These emotional changes are common, but the mother may think these changes are abnormal. You know, one time my brother's wife was pregnant and they were playing game and she sat down to play. I don't know who pushed her, but she was kind of upset already. Nobody knows why she was upset. That was when I saw this emotional thing and it just stuck in my mind. What changes a pregnant woman? She's a happy woman, I know. She sit down, she played a game with her husband, she lost. And she was boiling up. It was like somebody just threw a stone on her head. She was so pissed off. She was upset. She started crying for no reason. So all these things are expected signs in pregnancy. They are all changes. So body image, I have mentioned that already. You have to educate the woman about their body image. They have the stretch marks and all that, the curvature thing. And after delivery, the womb will be still high up. And with days, it come back to normal. So body images, their body image is going to change. After you have the baby and you have stretch marks, it's not gonna just clear off in one day. Discomforts of pregnancy, nausea, vomiting. I don't want to go about it. I spoke about it, but this will usually occur in the first trimester and it will subside by the 3rd month. So usually the first trimester, there will be nausea, vomiting. For those who get hyperemesis, I will talk about it. It's a disease condition in pregnancy. So you encourage them to eat crackers before rising. You're trying to help them to stay up and cope with it. So you encourage them to eat crackers, dry food stuff before they come out of bed. They avoid brushing their teeth immediately after they rise up in bed, eating small, frequent, low-fat meals, drinking liquids. I'm going to jump that. Then you teach them about syncope. So your nursing interventions, like I said, interventions are what you, the nurse, would do. This is what NCLEX wants you to know. So what you will do for the patient, it's not the patient who came to do anything for you. So the 4 patients they are going to present to you on the screen, put yourself right sitting in the clinic, right sitting in the hospital, or sitting as the nurse on your desk right now. And then they give you 4 patients. And the 4 patients are having discomfort in pregnancy and you have to intervene. So the patient come to you and say, oh, I think I missed my period this month. And for the past 1 week, I've been vomiting, I've been dizzy, I've been weak. That's the syncope I'm coming to talk about. I've been having this discomfort. I just feel weak and too tired to do anything. I don't have appetite. So this is where your interventions come in. So you assess the patient. This is where the nursing process as well come in. So you're assessing the patient, you're getting more information, then you are intervening, you are educating. So you tell the patient, eat crackers before you rise up. These are your educational information you'll be carrying out to the patient. So if you don't understand what the patient complaint is, NCLEX is not going to tell you this is hyperemesis or this is nausea, vomiting. I miss my period and I have this and that. I know this will be easier for at least for ladies who have been pregnant. You will know that these are signs of pregnancy. So you start educating if it is confirmed that it is pregnancy. So if the patient did a home test and tells you I did a home test, then you now do education. So syncope usually will occur in the first trimester. Remember, there is nausea, vomiting. So if there is nausea, vomiting, that tells you that with the nausea, vomiting, there's blood volume depletion. There's reduction in blood volume. Give me a minute. Remember this house. We don't have greedy people in the house. Okay. So you teach them to sit and elevate their feet. You also teach them about risk for fall, changes in position, to wake up slowly. So you want to educate these patients with syncope. Syncope is because of the increased blood volume demand in the patient that is pregnant due to hormonal triggers. So hormonal levels have increased and there's the need for more blood. And now here comes this woman vomiting and not retaining any fluid in the body. So there's already an imbalance. So that will cause syncope and anemia, fatigue. You will see them in the first trimester with dehydration as well. So the nurse need to instruct pregnant women to avoid lying in the supine position, particularly in the second and third trimester. The supine position will place the woman at risk for supine hypertension. And this one occurs as a result of pressure on the uterus on the inferior vena cava. Remember, the inferior vena cava is the one that carries blood back into the heart. So if the inferior vena cava carry blood into the heart and you lie supine and the whole fetus move up and put pressure on it and pushes it to the corner, it limits the flow of blood through the inferior vena cava into your heart. That's why you become hypotensive, or you get the syncope, dizziness. So this is what you tell the pregnant mother. So when you are second trimester, you can no longer be sleeping supine. You cannot be lying on your back. I have a lady tell me, oh, I was just sleeping on my back and sometimes I'm not comfortable, sometimes I cannot breathe. So sometimes the discomfort will naturally limit you. So there will also be urine frequency and all that stuff. So what will you educate? Urinary frequency and urinary urgency will always occur at least in the first trimester and in the third trimester. So in the first trimester and the third trimester, urine frequency occurs because remember the position of the uterus in the first trimester is just below the symphysis pubis. So because the uterus is right there, it's bumping up and increasing, putting pressure on the bladder. And on the third trimester, it's all over the stomach and it starts dropping down because the baby has now assumed a position to come out and the position is just putting pressure on the urinary bladder. It reduces the size. So this will cause frequent urination, so constant running to the bathroom. The second trimester, the baby is all the way at the umbilical to a little above the umbilical level. So I'm going to get that picture for us to see when we come back from our break. So the baby is above the umbilical level in the second trimester. So that lifts pressure off the urinary bladder. So it doesn't put too much pressure on the bladder and the mother doesn't have to be peeing every few minutes. But the third trimester, it starts reducing and there's pressure on the urinary bladder. So breast tenderness, if the breast is tender, you teach them this will occur in the first trimester and third trimester, and it's caused by estrogen level and progesterone level. Intervention is wearing supportive bra during pregnancy and after delivery when they are breastfeeding especially. So there's increased vaginal discharges. I spoke about it. You teach them to use proper cleansing, hygiene, and techniques, wearing cotton underwears, avoid douching, and then they consult healthcare provider if there's infection suspected. So if the patient describes to you the symptoms and you don't think these symptoms are describing normal vaginal secretion, they are not white, they are brown discharges and it smells. It might be UTI, and if I have burning and discomfort when I urinate. So I have fatigue. This will occur first and third trimester, and usually it's just the hormonal changes. You are tired for yourself. Intervention, arrange frequent rest period in between the day. That's what you want to educate the mother. Obtaining regular exercise, and then using correct posture and body mechanics. It's not a discomfort that you can give medication to have it relieved. It's just a normal process the body has to go through. Now we have heartburns. Heartburns occurs in the second and third trimester. And this is a result of increased progesterone levels that decrease gastrointestinal motility and esophageal reflux and the displacement of the stomach by the enlarging uterus. So you know that when the woman is pregnant, and like I had explained, the uterus keep increasing and increasing. And this is all located in the abdominal cavity. If you remember the GI system that we did, you can remember where the descending column, the lower intestines, or the small intestine, yeah, not the lower. The small intestines are located, and how the large intestines line the whole stomach like this, all the way down to the rectum. So if it's all lined like that, and the uterus is supposed to be at a portion, and now it starts increasing and increasing and increasing, it's pushing the GI system to one side. It's making it so tight for the stomach to empty its gastric content. So since the stomach is not able to empty its gastric content because there's pressure being put on it, so the stomach is not it's not free enough. So you're eating this food, and it's progesterone increase in your intestine, so motility is reduced, the digestion process is reduced. So since digestion process is reduced and the food is staying there, instead of having it digest and go normally and come out, it doesn't do that. There is heartburn. You start regurgitating the food through your esophagus, it start coming back. So you start having acid reflux. That's the heartburn. And also you start having constipation because of the increased progesterone levels. It start giving you constipation. It's not helping. Digestion is not so frequent. So this is the effect a pregnancy can also have on the GI system. So GI system can also affect pregnancy in that way. Increased hormonal level, and then increase in the size of the stomach, pushing the stomach to the side of the abdominal cavity, because the uterus and everybody is inside the abdomen. Now, where am I? I spoke about heartburns, the interventions. We know that already. I want to believe we can all manage that. So you teach them, milk, drinking milk in between meals, sitting up, drinking. The milk will help with the heartburns. You can eat some yogurt. You teach the mother yogurt is fine with heartburns, eating small, sitting upright after eating, avoiding fatty foods like chicken nuggets. It will help. This is when you also have the pica tent, where you want to eat everything, but you try to avoid things that will not help with digestion. So you also perform tailor sitting exercise. You try to sit down and you try to stretch yourself to have the food come down, or you can stand, walk around, resolve vasodilation. And then usually this will occur in the second and third trimester. So it's not true at the pregnancy. First trimester, you may not have all of that, but had been set in second and third. It is very difficult. So this one is about edema. This one is when there is edema. So when a patient has edema, usually edema, you want to be worried about this. This intervention here is edema interventions. You want to be worried if the patients, after 20 weeks, start having edema of the ankles. So you start talking about preeclampsia symptoms to them, starting from 20 weeks. You start educating them if preeclampsia will usually set in after 20 weeks going. So you tell them about it. But if the patient had previous pregnancy with preeclampsia, then you want to start educating the patient early. You just start taking notice. So it's a higher risk person than somebody who never had preeclampsia. So you educate them about elevating their legs and sleeping in a lying position, side lying position, wearing supportive stockings to avoid edema. Now let's talk about varicose veins. This occurs second and third trimester, result from weakening walls of the veins and valves, and venous congestion. Thrombophlebitis is rare, but it may occur. Thrombophlebitis, inflammation of the veins. Now, the management of that is supportive stockings as well. Elevate the feet when sitting down. So remember, it's not only edema that will make you elevate, but when there's varicose veins too, you want to educate them to elevate. The last time if I remember one of the systems I was telling you, or I don't know if it's in one of the videos, I was telling you that if a patient has venous problem, if the patient has venous, like deep vein thrombosis, you want to, or cellulitis, yes. So you want to encourage bed rest. But when it's an arterial problem, you want to encourage them to move. You don't encourage bed rest. If it's a vein problem, you encourage them to rest. But if you elevate it, but if it's arterial problem, you don't encourage that. It's opposite. Now, headaches. Pregnant women usually have headaches first trimester. You also want to know about that, to just educate them to change positions slowly, apply warm cloth to their forehead, and then they should eat some snack, and they can use some Tylenol as prescribed. I'm coming up with a pharmacology information. In that information, I have pregnancy category A, B, C, D, and E. These are medications that fall in the categories of pregnant, what a pregnant woman can take. Anything in category X is no, no, no. Pregnant woman don't take that medication. I'm going to give that, that to you, but I'm putting it together. I'm almost done with that book though. So I have hemorrhoids. Hemorrhoid too can occur in the second and third trimester. So you encourage soaking in a warm seat bath, sitting on a soft pillow, eating high fiber diet. This you can also do. The high fiber diet, you can also educate the patient with the constipation and other stuff. What happened to my computer? Okay, now backaches. I'm moving. I have constipation here. I think I already spoke enough about constipation, but just to mention this, if a patient is taking iron, so you want to let the mother know if you are taking iron, maybe you are anemic, or you are it's a prophylactic to prevent any anemia during the pregnancy, you're taking iron, you are at risk for constipation. You increase fluid intake, so you encourage fluid and fiber. Sometimes if it's that severe, they will order stool softness, colic. So we have backaches, which I spoke about, usually second and third trimester due to the curvature that pull your cervix up and make your backbone curved. And you want to encourage bed rest and all that. You educate the patient to sleep on a firm mattress, and you also want to encourage them to lie on the side and try to avoid supine position in the second and third trimester. Leg cramps, this usually in the second and third trimester as well. And the result is as a result of calcium phosphorus balance and pressure of the uterus on nerves or from fatigue. So you can have leg cramps as well when you are pregnant. So you want to teach them to get regular exercise, especially when they are walking. You tell them to walk. They encourage pregnant people to walk. Dorsiflexing the legs and increasing calcium intake. Shortness of breath can occur in second and third trimester, result from pressure on the diaphragm for the enlarged uterus. Now, shortness of breath, I have mentioned that already. When the pressure is coming up, when the baby is being pushed, is pushing up the upper structures, pushing them, everybody is going to their corner. I wish I could show you a picture of the GI system again, like I had done. I have it anyway. So, but the abdomen pushes everybody up and everybody is constrained. So around the chest area, all the organs in the thoracic cavity, the liver, the heart, the lungs, they are all pushed to the corner, and the stomach is coming from the way, just underneath the diaphragm. It puts pressure on all of them. So this, remember I talked about the pulmonary circulation, blood increase, it will cause shortness of breath as well. So you educate the patient to take frequent rest in between activities to avoid overexertion, sitting and sleeping with the head elevated on the side. So this is what you want to educate the mother. Now, maternal risk factors. Maternal risk factors is Women, maternal age is a risk factor. These are factors that will affect a pregnant person. So age, so women that are younger than 20 and those that are older than 35. So those with lesser maternity risk factors will be 20 to 35. But before 20 and after 35, I know we all know this, you want to monitor them for risk of adverse prenatal outcome. So prenatal period is the time of pregnancy that the mother start coming to receive care until labor. So prenatal starts from initial diagnosis of the pregnancy till the time of labor. So I'm gonna come in with labor as well. The last time I talked about the monitoring of the contractions and all, but so when you talk about the maternity risk factors, adolescent pregnancy, we know they come with a lot of immature bodies, and because they are not matured as well, they do have that problem. The body is not well built up, and now they have to share it with a growing fetus. Now, remember the last time we were talking about the Clementina, if you can hear me, we were talking about consent, signing of consent by teenagers, signing of consent by a lady that is a younger person. This is legal nursing. I said if you are 15 years old, you're a juvenile, and then you have gotten pregnant, and you are pregnant, and you decide that you want to keep that baby, you can keep that baby. And when you decide you want to take that baby, you can abort. That's your baby. Now, when you have that baby, you give birth to that baby, you can decide what you want for that baby. Your mother cannot decide for you. But if you are not married and you are staying with your parents are still, you are still a minor, you are still less than the recommended age to sign consent. So your parents will still be the people to give consent for your treatments. And then you can also give consent for your baby. If you decide to go and get any birth control, that you will sign consent. Your mother doesn't have to sign consent whether you should get a birth control after delivery or not. You are a minor, but you can sign consent for birth control. So take notice of that. But when you are married and then you are still 15 years, 14 years, and you are married, then you assume adult responsibility. You are free to sign every consent of your own. Anyway, that was just on the side. But take note when NCLEX start asking you questions about consent. So women of childbearing age should take folic acid. So neural tube defect. I was talking about physiological integrity today. I spent like almost half of my day talking about physiological integrity and that basic care and comfort stuff. So I was talking about neural tube defect. I was making a video, okay? I wasn't giving it, I wasn't sending it out. So that's why, Juliet, you couldn't reach me. I was busy all evening. After I finished talking to you, I got hooked up and I had to make a couple of videos. So neural tube defect, we have things like spina bifida, where the babies are born with unclosed spine. Their spine, instead of having it closed, it have a pause. So there's space in between. And then the spinal fluid that is supposed to be moving in our spinal cord, it goes and pushes it, and then it forms a meningocele cell. It formed like a little bump with meninges. It's very soft and fragile. So you see it on the back of the child. It's as a result of inadequate folic acid by the mother during pregnancy. So it's a neural tube defect when a baby is being formed. Nobody knows the cause. It can be hereditary. But when a woman is at risk, especially above 35, is at risk for giving birth to a baby like that, that's why the recommendation is that you can educate a pregnant woman to start taking folic acid at least 3 months before they get pregnant, especially if they have advanced age. So folic acid is usually the problem. for neural tube defect. So in case they ask you spina bifida, I didn't take a picture of that. I would have shown you that picture, what I was doing today. But spinal bifida is a neural tube defect, and it's as a result of inadequate folic acid consumption by the mother. So usually advanced age count. Genetic consideration. So genetic abnormalities such as defective genes, transmissible inherited disorders can result in congenital abnormalities. We have cleft lip, cleft palate. The last time I sent my student to see a baby with cleft lip, they were so excited. That was the first time they saw cleft lip. They saw that the baby lip was wide open, but the baby was feeding okay. So for a baby that has cleft lip, if it's the lip, remember we have cleft lip and cleft palate. I think I'm jumping into something else, but let me just say that quick. Cleft lip is when the lip is divided into two. The palate may be intact. So the baby may not, if you're educating a mother with that baby, the baby may not have feeding problems. The baby will not have any problem feeding, but you are still concerned. You want to educate. There will be, the mother will have problem coping, holding a baby with the lips separated like that. So you educate them. If it has not gotten into the nose, we have the palate, cleft palate. Cleft palate is the one that under your palate on top there. When that one is all open, it starts from the up here and it open all the way. The lip is open, it open gets to the nose. You are concerned about aspiration, feeding those babies. Cleft lip may not be a big concern for aspiration. It may be a problem of body image disorder, but if it comes to cleft palate, you are concerned about aspiration. So when you educate the mother, even though the body image is a problem, but you are concerned about the feeding of this baby because the baby can aspirate because it's going to open all the way to the nose. They do a surgery to close it with time. Anyway, that was just by the way. But just take note of how you educate mothers who present with babies like that when NCLEX give it to you. So understand that the cleft palate will have an effect to the nose because the palate is the lining bone that the nose is on top of. So if that one is all open from here inside, aspiration #1 concern. So nutritional imbalance is a problem. Usually they will have a tube to feed the baby. Okay, let's talk about German measles, medical conditions or abuse and violence. Well, abuse and violence, we know this already in our society. Mothers who are being abused, they are at risk for placenta abruption, preterm birth, and infection from unwanted and forced sex. So these are all about abuse. So you want to take notice of that. Let's talk about maternal medical conditions during pregnancy to be mindful about. We have current medical conditions such as, but not limited to, diabetes, hypertension, cardiac, increased risk of complication during pregnancy, increased risk. So we have German measles. So these are all screenings that will be done when a woman is pregnant. So they will screen the woman for German measles, which is rubella. So this is maternal infection during the first 8 weeks of gestation, carries the highest rate of fetal infection. So it will be done the first 8 weeks of pregnancy. They try to screen the mother of this. That is if you go early. People like me, we don't go early. We go for maternal versus second trimester. So don't be like me though. Then we have sexually transmitted infections. Syphilis, we have gonorrhea. I'm not going to go into details with this. I don't know if we actually want me to talk about them, but these are STDs. Let me mention them in general. We have syphilis, gonorrhea, chlamydia, trichomonas, and genital herpes. So these are screenings that will be done in the prenatal period. So syphilis is an organism that can cross the placenta. So they screen the woman for this in the early stage of pregnancy, usually in the first trimester. They will do syphilis. I see. Okay. So they will do syphilis screening because it can cross the placenta and affect the baby. So infection usually leads to spontaneous abortion and increases the incidence of mental subnormality and physical deformities. So this is the reason why they do it. So we have the condyloma acuminatum. I don't want to talk about it. NCLEX will not push us that far, especially for the LPN, we will not be pushed this far. You just need to know the transmission. Transmission may occur during birth. So you need to know that transmission can occur from mother to baby during birth. And you need to know that it crosses the placenta and it can cause abortion. It can cause abortion or fetal deformities. Gonorrhea is contaminated, and in gonorrhea, the fetus is contaminated at the time of birth. So if the mother has gonorrhea, there's no problem. Nobody will notice, but the risk is that the baby can be exposed to it during delivery. So the risk to the neonate will include ophthalmia, neonatorium, and pneumonia and sepsis. That's why usually when babies are born, you see they put the vitamin K right in their eyes immediately after birth. It's to prevent any, even though mommy was screened and mommy did not have anything, but it's just to be on the safer side of any unforeseen circumstances. So maternal infection may result in postpartum infection of the neonate. Now let's look at chlamydia. So chlamydia may occur during vaginal birth and can result in neonatal conjunctivitis and pneumonitis. That's the main one too. So infection can occur if the woman has eclampsia and it was not seen and treated in the pregnancy. It can cause premature rupture of the membranes. It can cause preterm labor and postpartum endometritis. That's inflammation or infection of the uterus. So that's what chlamydia can cause. So all these things the women get screened for if you are pregnant. Genital herpes, painful lesions, fever, chills, malaise, dysuria may last 2 to 3 weeks. I'm going to go over that. I'm not going to talk about it. Don't worry about it. Just know that it's part of the screenings they will do when a woman is pregnant, especially chlamydia that can cause preterm labor, gonorrhea that can also cause ophthalmia, neonatorium, that's visual problems, and then syphilis that can cause deformities, mental and physical deformities, and spontaneous abortion. HIV/AIDS. HIV/AIDS is usually transmitted to the baby during birth. So most often they will take precautive measures when the woman has HIV/AIDS. So prenatal administration, okay. So having HIV is transmitted through bloodborne. I had tackled this topic with the other group before. Is bloodborne and other bodily fluid that is transmitted through secretion. So during delivery, repeated exposure can have the baby get HIV. So prenatal administration of zidovudine, this is one of the antiretroviral medications. It is recommended to decrease the risk of transmission for HIV/AIDS from mother to fetus. So it is one of the safe medications that the mother can take with pregnancy. So a pregnant woman who is HIV positive will be taking this medication for pregnancy. Other ones may be restricted because they can harm the baby, but this one is safe for the baby. So you take it to prevent cross-infection. And delivery, they usually have a well-organized delivery to, yeah, oh, John. They usually have a delivery process to help so that it doesn't cross through the placenta. They take extra precautionary measures. So even though the woman can deliver vaginally, just to let you know, the woman can deliver vaginally. Hepatitis B, the woman can deliver vaginally as well. But they can ask you, how will you protect yourself? I have somebody tell me that they gave her a question on the NCLEX and they wanted her to explain how she will protect herself when caring for an HIV positive patient. They want to know if you understand that this is a blood-borne infectious protocol. So you need to know, what do you need for blood-borne? A patient who is a blood-borne, like if I have to put in the precaution measure for a blood-borne. So you use blood-borne and standard precaution to care for such a patient. So the delivery team for a positive HIV positive mother will also take same precautions to deliver the baby, knowing very well that they have to try to prevent the placenta from causing a cross contamination to the baby. Now, I'm going to talk about antepartum diagnostic testing. Antepartum, that's the during pregnancy. What kind of testing will they do during pregnancy? So these are the things I put down, but I'm going to pause here. I think it's even time for us to take our break. So it's good time for me. I'll just consume extra 15 minutes. So I'm going to put the video up in 15 minutes so that we watch that. Juliet, I would really prefer you to watch that video. I'm going to put the nursing process video. Which one was the shortest video we did the last time? I usually do some extra endless explanation before I go into the content. So I'm going to put one of the videos up in 15 minutes. So you can log in 15 minutes and watch it. After that, I will come back and then we'll finish up for the day. Okay. So it's 7. Oh boy. So basically we'll come back at 8. Will that work, or we want to go to work? Can we come back and just finish up? Let me see how much of this we have. We're almost done. Look, we are here. Yeah, we're almost done with this. So we'll come back at 8 o'clock and we'll finish this one. And then, but before that, does anybody have a question? Or you want to write your question later? If not, we can go for break now. 15 minutes, I'm going to put the video on. Like, this is 35, 34, I would say. So like 7:50, I'm going to put up the video, how to answer the questions video that we did the last time, so that you watch it. Okay. So if there's no question, I'm going to hang up here. I'm not going to log out today, so I'm just going to mute and off myself and join the other Zoom. Okay. So we're taking a break. So 7:50, you can log back in and then that video will be playing for you. Okay. Thank you very much. I will see you in 15 minutes.
Okay.
Yeah, so hepatitis B and HIV positive mothers, it doesn't mean it necessarily cross, or it doesn't necessarily, the baby doesn't come out as a positive baby. So that's why in the delivery process, they try as much as possible to have them deliver. But when it comes to HIV mothers, usually they try to like encourage them not to breastfeed. Hepatitis B, the woman get the vaccine and the baby is good to breastfeed, and the baby still continue the regular process of the immunization. So the first 1 month, then 4 months, and then the next 6 months. So the baby gets the right dosages of the vaccine. But in HIV, they try to not to let the mother breastfeed. By hepatitis B, the mother can breastfeed. Any other question?
No, that's it. Thank you.
Anyone else has a question? I was able to join Redeemer's meeting, okay? Anyone else has a question? Okay, so we were coming to talk about the diagnostic testing, but I had said I was going to get a picture. I didn't get a picture that I was looking for. I did have a picture that I wanted to explain for the fundal heights. For the fundal heights per the this thing at the 22 year throughout the weeks of pregnancy. So I will get it. This is just an improvised image, but I'm going to get it. I have a picture that I've explained very well. I'm really looking for that picture to give you a clear explanation of what I want you to understand about this. So, but for this particular picture here is just to show you a normal fundal height and abnormal one. So if I come to you and I say I'm 38 weeks pregnant and you measure the fundal height and it ends up here, it doesn't go well. That means there's a problem. 28 should be here. It should not be all the way up. That means the baby is growing bigger. You know, we have gestational diabetes and other stuff that cause big babies. So it should not be too low, it should not be too high. It should be within normal limits. But anyway, let's go back to what we are going to talk about now. And then when I finish, we can go into other stuff. Okay, so I was going to talk about diagnostic testing, antepartum during pregnancy. So pregnancy is divided by prenatal, antepartum, and postpartum. Those are the three main components. So we finished prenatal assessment and what you will see, the body changes and everything, and the assessment that they will do in the prenatal time. So antepartum during pregnancy. So all these tests will be repeated during pregnancy as well. The HIV, herpes, chlamydia, and all those things, they'll do them in pregnancy as well. So antepartum testing, this one is usually scheduled for antepartum healthcare visits, and it's every 4 weeks for the first 28 weeks. So if a woman is pregnant, the first 28 weeks, you go to the doctor every month. And then after that, from 28 weeks to 32 weeks, you go every 2 weeks. From 4 weeks is for the first 28 to 32 weeks. So from 28 weeks to 32 weeks, you go every 4 weeks. You go once a month. Then every 2 weeks, you start from 32 weeks to 36 weeks. So the weeks of the pregnancy from 32 weeks to 36 weeks, you go to the doctor every 2 weeks. And from 36 weeks to 40 weeks of pregnancy, you go every week, once a week. And after 40 weeks, if you are 40 weeks and the baby has not come, you go to the doctor every other day. Every other day. They will either, you will educate the mother about inducing labor, or you have them come every other day. And after 40 weeks, if the baby don't come, they have to do a fetal stress test. They have to do a fetal stress test. They have to test to see if the baby is not stressing out, or overgrowth test to see if the baby is not overgrowing inside the uterus. So take notice of the teaching schedule that you tell the mother. So you tell the mother that you will have to see the doctor from now until you are 28 to 32 weeks. You will see the doctor every week. Every month you'll be coming once in every 4 weeks. Then when you are 32 to 36 weeks, then you come every 2 weeks. And from 36 to 40 weeks, the baby can come anytime, but you will need to come every week to see the doctor. That's the education you give. Now the rhesus factor, they have to do blood type and cross matching. They have to do type and screen. So type and screen is one of the only blood tests you will do that if you mix it up, if you mix my blood and your blood, there's a big problem. You can accidentally mix urine, which is actually not encouraging. But for blood, if you mix it up, you have a big problem. So we have the ABO type, which is performed to determine the woman's blood type in the ABO antigen. So I think I had sent, I don't know if I sent out this video. Did anybody watch any of the videos on pharmacology and IV? I did a video under blood administration, blood and blood products, and the types of blood transfusion reactions for you to take note for the NCLEX. I shortened that video and I describe it. I don't know if somebody watched that video or if I gave it out, I'm not sure, but I know I have a video on that says type and
No,
course.
I don't think we got that one.
Oh, you didn't? Yeah,
No.
I think I have it. I have it.
Okay.
Okay. So if I mention some of these things, just send me a text later if I don't do it and remind me and I'll do it. Sometimes it's just too much in my brain. So we have the RH type. So the RH rhesus type is done to determine the woman's blood type in the rhesus antigen system. So we have the RH positive and the RH negative. I'm not going to go into this because I know most students usually get this confusing. So I don't want you to get confused with this. Just take RH plus and RH negative. If you have a paper, write it down. Just put RH plus and RH negative. Let me explain that to you. I'm not going to go into details. I'm just going to go into what you should know. RH plus, RH negative. So the RH positive will indicate the presence of an antigen. So the plus tells you the patient has an antigen. The negative tells you the patient does not have an antigen. So if you don't have an antigen, you are negative. So if you are negative, I'm coming to ROGAM. If you know what ROGAM is, that they give to the mother, I'm coming to explain that. I know students get confused. I taught maternity last semester with my student at Concordia. So I know they get that confused. Now, if you have a woman who is RH negative, and you are pregnant, and the baby if you are RH negative, that means you don't have the antigen. So if you don't have the antigen, you need ROGAM. Okay? You will need ROGAM. So she will need to repeat antibody screening and should receive ROGAM at 28 weeks of pregnancy. So if you are RH negative, so under the RH negative that you put an arrow down and then you put the need ROGAM at 28 weeks. So RH negative mother will need ROGAM at 28 weeks of pregnancy. If you understand this, you don't even need to read these notes. So RH negative need ROGAM at 28 weeks and after delivery. So 28 weeks, you need ROGAM. That's it for the NCLEX. When you come to the floor, they can tell you 26 to 28 weeks. It is normal. That's the normal range, 26 to 28 weeks. You will need ROGAM, first ROGAM. This is the point that the mother body starts recognizing the baby as a foreign object because the mother doesn't have any antibody. The mother is rhesus negative. The mother doesn't have an antigen. So you start recognizing the baby's body as a foreign object. So if the mother don't get the ROGAM to stop the effect of the wrong identification of the mother's body that the baby is a foreign object, this can cause miscarriage or loss of pregnancy. So at 28 weeks, presumably the mother body has started recognizing. Now this is given for first time pregnant mothers. No, I'm sorry. For the first time a woman is pregnant, if you are RH negative, there is no problem with the first pregnancy. First pregnancy, you are free. The baby is good. You don't need ROGAM because it's not, your body have not become sensitive yet. Even if it's your first pregnancy and you get miscarriage, it is recorded. Your body have recorded that you have been pregnant before and I am negative. I don't have the antigen. So the next pregnancy you start, you will need ROGAM to have that baby alive. So you need ROGAM after your first pregnancy. So first pregnancy, no need for ROGAM because the body is not sensitive yet, has not recognized it. But second pregnancy and the rest, you need ROGAM at 28 weeks. If not, you'll be getting miscarriages. That's why sometimes you see a woman trying to have a baby and it's just so hard. You get pregnant for some time and at a certain point, the baby come out. I'm not saying that's the only reason. There are multiple factors, but I'm just talking this in reference to when a woman needs ROGAM. And after the baby is born, the first 72 hours, the mother still gets ROGAM. So let's look at rubella titer. We know measles, mumps, rubella. I spoke about German measles. So if the client has a negative titer, I don't want to talk about the details of this titer value here. Just take note that if the client is negative, it indicates you are prone, you are at risk for getting the rubella virus. That's it. That's the only thing I'm going to say here. I know things that make people so confused. So when you are teaching the patient, just let them know if you are at risk, if you have never taken the rubella vaccine, measles, mumps, rubella, if you've never taken any of that and they do your titers, then if it shows that you don't have it, you haven't taken it some point in your life, then you are at risk for the virus, you're at risk for infection. Hemoglobin and hematocrit. Remember I told you blood volume will increase. So you're going to need to do the hemoglobin to check to see if the mother is at risk for anemia. And if the mother is at risk for anemia, that's where iron comes in. They start taking iron. Then monitoring the patient for sexually, I have this one. Papa Nicholas smears. So this one is the screening they do, or papilloma screening. They do this for cervical cancer. They just do that screening. They take a sample from your cervix and they screen it. If you have done cervical screening before, this is the testing they do. So pregnant women too, yes. When you are pregnant, they do that for you. Then monitoring for STDs, and the laboratory test they will do. They will screen you for gonorrhea as well. I had mentioned that in the past. These are the same disease conditions, and I'm letting you know that they will do screening for all of them as well. So you screen prenatal and you screen intranatal. You screen intranatal. 2 screenings you will do for all the STDs. Now let's talk about HIV. HIV screening. I'm talking about it not only for maternity nursing, but to let you know for other purpose of NCLEX asking you questions because they like to dig more into stuff like that. So let's talk about HIV. So HIV testing is done for high-risk clients. Clients test to determine the presence of antibody. So they do the ELISA testing. ELISA and Western blot, ELISA, Western blot, and immunofluorescence assay. So take notice of ELISA test and what it is. Take notice of Western blot. It is test they do for HIV testing. So ELISA is enzyme-linked immunoabsorbent assay. So they first of all, they take the mother's blood sample when you first visit. They take your blood sample, they screen you for HIV. So when it comes back positive, then they now order the ELISA testing, and that one is the screening one they will do to make sure. Then they do the Western blot to confirm it as the amount of viral load that you have. I have it into detail somewhere in another chapter. So the Western blot is the confirmatory test for HIV testing. So hepatitis B. Hepatitis B. Give me a minute. Let me close my. Okay, so hepatitis B is testing for antigen is recommended for all women because of the prevalence of the disease in the general population. So hepatitis B screening too is done for pregnant mothers as well. So hepatitis B vaccine is contraindicated during pregnancy and may be recommended by the primary health care provider. So when a woman is pregnant and they are positive for hepatitis B, or even if they are not positive, is contraindicated. You are not supposed to get it. You can get it after you have the baby. So it's the same way as the hepatitis treatment too. So if you are pregnant and it's realized that you've not been treated and you are pregnant, they will try to let you have the baby. They give the baby the vaccine, you start breastfeeding, and then you start the hepatitis treatment after delivery. So glucose tolerance test, oh my goodness. This is the glucose one, if you have ever done that testing. So we have the 1 hour testing. I'm not going to go into details with this, but just understand this. I want you to have a baseline understanding. We have the 1 hour testing. So the amount you drink is the 50-gram oral glucose. And then they have you wait for 1 hour. So you wait for 1 hour after drinking that, and then they draw your blood to check. If your glucose level or A1C level is high, then they have you come back another day to do a 3-hour testing. So the amount of glucose drink you will get is 50 grams usually for 1 hour screening. And then if it's positive or if your A1C is high, you come back another day for a 3-hour wait. So after drinking that, you wait for 3 hours and they draw your blood again. Now, urinalysis and urine culture, ultrasound. This is the confirmatory test for pregnancy. It outlines and identifies fetal and maternal structures. Usually a complete ultrasound is done to obtain the baby structures and everything. And we also have a transvaginal ultrasound, and this one is used during the first trimester. Usually that one, they use a probe. They use a probe and they insert it through the vagina to view the baby. So the intervention is an abdominal ultrasound is being performed. The woman may need to drink water to fill the bladder. So let the mother know. Your education will include having the mother drink a lot of water. You want the bladder to be full. This will cause distension of the uterus. It will push the uterus so that the uterus is bumpy enough for them to see. Usually it's in the first trimester. So the baby is very small inside. So when the bladder is full, it does help for visualization. So we have the biophysical profile. This is also a non-invasive assessment of the fetus that includes fetal breathing movement, fetal tone, amniotic fluid index, and fetal heart rate prenatal via non-stress test. You are not worried about this. You just need to know to educate the mother to have a full bladder, to drink water for the ultrasound. Doppler blood flow analysis. This is ultrasonography method of studying this is the Doppler I was talking about. It's just a small machine. They use it, they put a gel on it, and then they try to listen for the baby's heart rate, and they count it. So I know we understand what that is. So we have the percutaneous umbilical blood sampling. In fact, I don't want to talk about this one, especially if you are writing for LPN. I don't want to talk about this. You don't need to worry about blood sampling and cord thing. It's annoying. They take in this procedure, actually, they take the umbilical cord, they take a blood sample from the baby's umbilical cord just through a needle, insert a needle to get the blood from the baby's umbilical vessel. And this one is done through a guided ultrasound. I don't even think you want to try that for your baby unless it's necessary. So we have the genetic testing. This is deoxyribonucleic acid testing, DNA. This is the DNA. This is the one they call the DNA, deoxyribonucleic acid testing, DNA testing. So they do this to determine Down syndrome. They do this testing to determine Down syndrome. And Down syndrome is characterized by three chromosomal defects. We have the Down syndrome trisomy 21, trisomy 18, and trisomy 13. So Down syndrome is classified into three. We have trisomy 21, where you have an extra chromosomes, if you remember that chromosomal effect. So we have trisomy 21, trisomy 18, and trisomy 13. They do the DNA testing, which also reveal the genetic or the Down syndrome status of the mother. This is a screening they do in pregnancy. So when you are pregnant, they do this screening. You might not have been told, especially if you are not at risk for it. Usually mothers above 35 are at risk for that. So they will always do that. But besides that, they do it for everybody. Chorionic villus sampling. This is performed for the purpose of detecting genetic abnormalities. They aspirate a small sample, chorionic villus tissue at 10 to 13 weeks of gestation. In fact, these are all part of the testing. So they just take a sample and they study it. Non-stress test. This is performed to assess placenta function and oxygenation. So test determine fetal well-being. Test evaluate fetal heart rate, response to fetal movement. So this is also the same testing they will do if the baby is more than 40 days. So if today is 40 days and baby haven't come yet, tomorrow, the next day, they start getting worried. So they're going to have you do a fetal testing, a non-stress test to see if the baby is being stressed out in the stomach. Now, the interventions for this one is an ultrasound transducer, and this is fine. You don't need to worry about this one, the interventions. All you need to know is that they do the stress to know how the baby responds to stress inside the stomach, because it's part of the screening. So it's an external ultrasound transducer and dynamometer, which they use to apply on the patient's stomach, and a tracing of at least 20-minute duration is obtained. So the fetal heart rate and uterine activity can be observed. So let me just explain to you how this happened. So I assume this is a mother's stomach. So this is a pregnant woman's stomach, and they want to do the fetal stress test. So they put the things just like they'll put it on for EKG. So they put it on, and then the thing is reading on the screen. It's reading and printing like a graph. So when the baby is kicking, it counts the kicks, and then it's reading the baby's heart rate to see. And then they tell the mother to turn on one side. When you turn on one side, you discomfort the baby. So the baby definitely will move. So when the baby moves, it reads how stressed the baby is. They have a limit. It shouldn't be abnormal, and the heart rate should be within normal limits. That's what this procedure is supposed to do. Amniocentesis. This one, we know that is, they take the amniotic fluid to go and examine it for abnormalities. So, or sometimes they want to see if there's enough fluid in there. So maternal risk for amniocentesis is maternal hemorrhage. The risk is bleeding. So number one risk for amniocentesis is bleeding. Infection. There can be infection in there once the baby is even still there. So RH ISO immunization, placenta abruptio, rapid spontaneous removal of the placenta, it detaches. So we have amniotic fluid emboli. We know embolism. So it's a problem. Then we have premature rupture of membranes. So after the chorionic villus sampling and amniocentesis, you want to instruct the client. If the client starts having chills, fever, and is bleeding or leaking fluid, the client sees some clear fluid coming out of the vagina, then there's also a decreased fetal movement, and uterine, when they start having contractions or cramping, they need to notify the doctor right away. You need to report that. This is a complication from the procedure. It can cause preterm labor, or it can cause infection. So if you have chills, fever, bleeding, fluid leaking, you have to report it as soon as possible. This is counting the number of kicks the baby has. So beginning 28 weeks, they will use the Doppler and then they listen. The healthcare provider will listen. So you instruct the client to notify the doctor if there are fewer counts that are 10 kicks in 2 times for 2 hours, or as instructed by the health provider. So you want to tell the mother that in every 2 hours, for every 2 hours, the mother should be able to hear or should be able to feel the baby kick up to 10 times. 10 times in 2 consecutive terms. So the baby should be able to kick within every hour. Let's say every hour, the baby should be able to kick up to 10 times. So 2 consecutive 10 kicks in 2 hours. So we have the FEN test. Is a microscopic slide that is used to determine the presence of amniotic fluid leakage. So when they suspect there's a leakage, it's just like those strips that they use, chemistry they use to drop to see the color change. So they use that particular stick, the FEN test. They use the slide, and then they dip it just like you do a urine dip to see the color change on the strip. The color change will indicate if there's the presence of amniotic fluid. I don't think I should talk about this. Let's talk about nutrition education. What will you educate a patient about who is pregnant? So nutrition education, we have pica. It's a problem. The woman wants to eat non-food substances, unnecessary things, some craving for, that's the craving. So pica refers to eating non-food substances such as dirt, clays, starch, freezer fruits, and many other things. So the cause is unknown. There's no specific cause. You cannot tell a woman this caused your pica, but let them know it's just an unknown cause that make a woman have a feeling for unusual things. But you also want to educate women who have the pica to their problem is iron deficiency anemia. Their problem is iron deficiency anemia for a patient who has pica. So the pregnant woman comes to tell you, oh, since I've been pregnant, I just feel like eating ice cream. I feel like eating only ice cream. I don't eat anything. I eat ice cream all day and all night. So you want to know what is the food nutrient in ice cream. Does the food nutrient in ice cream balance for a pregnant woman? This is a pica that is directing you to eat food substances. How about the one that say, I feel like eating clay all the time? Somebody say, I feel like smelling cow pee-pee all the time. She wants to be smelling what the cow is peeing, and she gets satisfied with that. So their problem is anemia, iron deficiency anemia. So you educate them to eat healthy diets. So non-stress test, we have the normal and the negative one. So that's probably the last section of what I'm going to talk about. So we have the no acceleration or acceleration of less than 15 beats per minute. I'm going to go into detail with this when I come to labor and delivery. I have it. I have a video on that, labor and delivery, that really explain the fetal non-stress test and the result. So this one, the non-stress test, we have the abnormal one and we have the negative one. So the unsatisfactory one, this result cannot be interpreted because of poor quality of the fetal heart rate tracing. So when they try to see how much the baby can take stress. So I'm just going to read this one to you. So the reactive will indicate a healthy fetus. So if the baby is reactive or the baby is responding nicely, it will indicate a healthy baby. Yes, Simone, eating ice. Eating ice is true. Eating ice is very true because they eat a lot of ice and that's what they want. The result requires 2 or more fetal heart rate accelerations of at least 15 beats per minute, lasting at least 15 seconds from the beginning of the acceleration to the end, in association with fetal movement during a 20-minute period. So you check that for 20 minutes to see how the baby is doing. Let me talk about the interventions because I realized that describing this one will not make sense right now. When we come to fetal stress test, I'm going to go into detail and how it is recorded on the graph. We have the decelerations and the accelerations. Now let's talk about the nursing interventions when you have a patient going for non-stress test, the normal and the negative one. You want to have an external fetal monitor that is applied to the client, and a 20 to 30 minute baseline strip is recorded. I told you it's read on a graph, on a piece of graph paper. So it's read and then it comes out of the machine. So you want to have that recorded every 20 to 30 minutes. And the baseline is recorded. Before you start the procedure, you want to have the first reading. Then every 20 to 30 minutes, you have another reading recorded. So the uterus is stimulated to contract by the administration of a dilute dose of oxytocin. Oxytocin by having the client use nipple stimulation until 3 palpable contractions with a duration of 40 seconds or more in a 10-minute period have been achieved. So for this test, they give the woman oxytocin. We know that oxytocin is used to induce contraction. So when you give it, you will induce contraction. And then you also want to have the mother stimulate the nipple to see how much the baby will move. So when you do that, it all puts pressure on the baby and have the baby move. Then you want to take note of the count. You want to be able to have a 3 palpable contractions with a duration of 40 seconds or more in every 10 minutes. Then the frequent maternal blood pressure, you want to continue checking that and reading it. And the mother is monitored closely while increasing dose of oxytocin is given. This is usually when you want to induce labor. So you do that when a patient is being induced, you want to check. Or if for some reason the woman start having contractions, like I had mentioned before, that starting from 16 weeks, they start having abnormal contractions, irregular contractions. So if it's too high that it has to be managed, this is what they try to do, the test for the fetal stress. So we have the negative contraction test, which is normal. A negative result is represented by no later deceleration. I'm not going to talk about this. Listen, guys, we have better things to talk about in the NCLEX than this. So I'm going to stop here. And then these are, just to let you know, these are tests that they do in the prenatal period, or intranatal. So we have prenatal and intranatal. So this is it for maternity nursing. I haven't gone into labor and delivery yet. I will talk about the risk factors for maternity nursing, for maternity or pregnant women, and then I talk about labor and delivery. I already have labor and delivery video made up before. So if for some reason we can't get there, I just jump in straight. So besides that, do we have any question, any concerns today? Anybody have a question from all of this? Let me see how many people are on right now. Patience, do you have a question?
No, suppose I'm okay.
Do you understand?
Yes.
Are you sure?
Yes.
Okay. Emilia, any question? Emilia, do you have any question?
I have a question. Earlier, when you were talking about the probability and the possibility of pregnancy, when it's possible that you're pregnant, that is confirmed by testing, like ultrasound and stuff like that. But like the probability of being pregnant is more like symptoms that you experience?
Yes. So we have the probable signs and the positive signs. Probable, that means you are just observing. You said, okay, I missed my period. So probable signs are what the woman would tell you. I missed my period. I feel my breast tender. I feel this, my discharges have increased. I have nausea, I have vomiting. Those are probable signs. But a positive sign that nobody can object to is what the doctor will assess and find through, let's say, the HCG level. You check the blood, you check, what is the name? You do ultrasound to confirm it. Those are positive signs. So probable sign and positive signs, they are different. Most probable signs will be reported by the mother.
So the probably you would say is subjective, and then the possible is
It's objective most of the time, yes.
Okay.
Because you, the mother, cannot do ultrasound. When you come to tell me you are pregnant, you did a home test and you are pregnant, that's fine. That's in urine, but they have to see, is there a sac? Is there a gestational sac implanted in your abdomen? So if there was no gestational sac implanted, you can be, we have false pregnancy too. So false pregnancy can make you read a home positive pregnancy test and bring it. So the positive sign are the confirmatory test. The Chadwick sign and all those things are probable signs that you are probably pregnant. But the positive signs are those that they will get it. The HCG level will read. Ultrasound will also indicate. The transvaginal ultrasound, which is the use of the probe to view the fetal sac, will also indicate.
So if, let's say, a woman is pregnant and she has a miscarriage, or she's experiencing miscarriage, would the pregnancy test still be positive?
Yes.
If she's carried? Oh, okay.
Yes. So if a woman is having miscarriage, let's say the first 3 days, you started bleeding today, and tomorrow you came to the hospital, and you came and you showed something that came out, some little drop, a big clot that came out. It's possible the baby came out. But remember, the hormonal level in your body is still elevated with the pregnancy. So when we do the pregnancy test, it will be positive, but that doesn't mean you have a baby in you. And it will take, like, they tell the people to come back usually after a week, and then they repeat it to make sure the HCG level is now negative, to make sure there's no pregnancy anymore. Even for those who do egg donation and then they donate their eggs, they get hormones, they inject them with hormones. When they come and you test them, you will get a positive result. But that doesn't mean the person is positive. The person has gotten hormones to be able to donate egg for fertilization purposes. So that's the IVF stuff.
Okay. Thank you.
Any questions? Anybody has a question? So if we don't have a question, anybody has a concern? So for Juliet and Simone, I'm gonna have you guys do a lot of work. I will send you a lot of work, a lot of videos. Not today though. I'm going to put them in order, and I'm going to increase maybe the workload for the two of you. I will increase your workload. Emilia and Patience, please, I'm waiting for my assignment. I'm waiting for my assignment. Get my assignment for me, and then we'll not have any. I'll not ask of it again. Huh? I'm coming. Okay, so I'm waiting for the week assignment. I haven't sent you this week yet. So Simone, you should be preparing for, hold on.